Right. Good evening, dear students. Welcome to the FMGE marathon. Subject is anatomy, and we'll be spending about 1.5 hour each day for 3 successive days. We're going to focus upon some of the topics which we think are important for your next coming exam. And what I start with is general anatomy. One question came to you on the planes. So let us focus upon this particular question. And as you see, in anatomy, there will be certain planes we talk about. Say for example, when we first are looking at this particular plane, it is the median or mid-sagittal plane. Sagittal means you have to take the section anterior to posterior, as is evident here. The section is taken anterior to posterior so as the body is divided into right half and left half. In the similar fashion, we can take a CT scan like as is evident here, or any radiographic scan. You can assume that right half of the body has been removed and you are looking at the left half of the body from medial view. So that will be a mid-sagittal plane. We'll talk about that. But comparatively, if you talk about the frontal plane, here you can take the section right to left and remove the anterior part of the body, radiologically of course, and looking at the posterior half of the body. So the plane here, which we are calling it as frontal or coronal plane, the section is right to left and dividing the body into anterior half and posterior half. You look from the front view basically. And corresponding radiological diagram is given here, which we'll be talking about. But as we talk about the third plane, which is transverse plane or horizontal plane, you are going to take the section in such way that the body will be divided into upper, that is superior, and lower, which is inferior portion. So the plane goes in such way that there will be a superior or the upper portion of the body and inferior, which is the lower portion of the body. Again, when we talk about CT scans or radiographs, we are always looking them from inferior to superior, and the corresponding pictures here. Let us talk about this as well. Now we have taken a transverse plane or transverse section, and you're looking from inferior to superior. As we magnify this here, you can notice that in this kind of picture, a CT scan, which is a transverse section, since we have taken it inferior to superior, this will be the right side and that will be the left side. On the left side, we can see the spleen, which is being evident here, and on the right side, most of the lever is on the right side, so this is the impression of the lever. Anteriorly, you will have anterior abdominal wall because this is a CT scan in the abdomen region. So anterior abdominal wall and posterior abdominal wall. Posterior abdominal wall, you can see this is the lumbar vertebra, the spinal cord is in the vertebral canal. This is the spine of the lumbar vertebra. So posteriorly, it will be the vertebra. And just in front of the vertebra, because you are in the abdomen, you can see abdominal aorta. So this is the abdominal aorta towards the midline, and left side is the pancreas also, which is evident here. It is actually one retroperitoneal structure, as is the aorta. So this is a section which is transverse plane. CT scans are usually discussed inferior to superior. Now, as we look at the other section which we talked about, the coronal or frontal plane, because this is coming in form of some MCQs. So you remove the anterior half of the body, look at the posterior half of the body. You can see that we have taken that in the lungs region, that is the thorax region. So you can see posterior half of the right lung as well as left lung. Now if you are mentioning that way, that this is the right lung front view and this is the left lung front view, what will be sandwiched between the two? Let me zoom this area. A frontal view or coronal section. So mediastinum, and in the mediastinum, the heart. So heart is evident in the mediastinum here. This is a coronal section, right to left section, and you look at, you can assume, front view of the body removed, and you're looking at the posterior view of the body. The question which came to you in FMGE exam was actually this type of diagram given to you, like it was in fact a sagittal section. Coronal section also one question has come. Sagittal means your section is anterior to posterior and removing one half of the body, looking at the other half of body from medial view or maybe lateral view as well. So this is mid-sagittal or sagittal plane, and as I magnify here, you see, since you have removed right half of the body and looking at the left half of the body from medial to lateral, you can assume there will be anterior and posterior bones, like as you see here in this particular diagram. The intestines are shown, the rectum is shown. Rectum is comparatively more posterior, and if you talk about urinary bladder, it will be more anterior. So which bone will be more anterior? The pubis bone. And which bone will be posterior? You can see here this one. This is the sacrum bone, which is posterior. The vertebra which are here, vertebral column, is comparatively posterior. That will be the posterior abdominal wall, and this will be anterior abdominal wall or anterior pelvic wall. So I hope you got my point that if we are talking about the sagittal section, section is anterior to posterior, dividing body into right and left half. If it is coronal section, it is going in such way that body will be divided into anterior and posterior half. And if it is the transverse plane, the body divides into superior and inferior half. Journal anatomy. Now, as we are just focusing upon the topics which are relevant for your next coming FMGE exam, let me just look at the chat as well. Good evening, good evening. Yes, Chaudhary, Yakshi Patel, Manisha. Yes, good evening. Will this help NEET PG students? Of course, it will help NEET PG students as well. But then FMGE level is slightly lower and NEET PG level is slightly higher. So I am not going into much detail or too much of the information which will be relevant to NEET PG. So maybe it is not very helpful for NEET PG, but definitely helpful for FMGE exam, because this is FMGE marathon basically. And then let me see, surgery and anesthesia PDF. That you can put the query to PrepLadder and they'll provide the PDF. Yes, of course. Robot की तरह पढ़ाते हैं sir. टाइम कम है तो रोबोट की तरह ही पढ़ाना पड़ता है. एंड देन ओके राइट, मिस्टर ग्रे इज बैक. Black, Mr. Black. Okay, anyway, let us continue. And now we move on to the histology. You have to take it from me that in histology they will always ask you regarding the epithelium. It's a universal topic, always being in the exam, appearing in the exam. And as you see, I have given you some of the surface modification also. They can ask you about cilia, microvilli, the keratin, all that. Now, different type of epithelia here, schematic diagram and the actual histology diagram. In fact, in FMGE, they are giving you even the histology specimen. So, let me zoom this area a little bit. And as you see here, there's a term written C. Now, what is this C? C is representing cilia here, and which is a surface modification, some thread-like processes. They move. And they can move the structures which are in the lumen. Say for example, when we breathe, we take the air inside. With the air, there is dust and bacteria coming. They'll be trapped in the mucus secreted by, say, respiratory epithelium, the goblet cell secreting mucus. So whichever air we take in will be having bacteria, dust trapped in the mucus, and that must be coughed out. We must cough it out of the body. For that purpose, we will have cilia. Cilia can be at other places also, like in the, a question comes, In the uterine tube also you need cilia to move the conceptus towards the uterus, because implantation should be in the uterus. What will happen if we don't have cilia, or if the cilia is not moving? For example, Carter-Jenner syndrome. Now if we are talking about the Carter-Jenner syndrome, which is immotile cilia syndrome, cilia is there but not moving, what will happen? In Carter-Jenner syndrome, there can be chronic sinusitis. Because you are unable to move the bacteria out, there will be chronic infections. Bronchiectasis, pus in the lungs. You are unable to cough the infective agents out, so they will stay in the body. One is chronic sinusitis, the other is the bronchiectasis, third is situs inversus. Liver is on the left side, spleen is on the right side, the heart is towards the right side, dextrocardia, situs inversus. In Carter-Jenner syndrome, why there is situs inversus? Because the embryonal cells, they need cilia, they move, and there is particular arrangement of the organs. If it is Carter-Jenner syndrome, there is a triad which I am talking about. In Carter-Jenner triad, I have given you the three things. What are the three things? Number one, it is the chronic sinusitis. Number two, bronchiectasis. Number three, situs inversus. But why situs inversus? Because embryonal cells, if their cilia is not moving, the organs will be misplaced. Situs inversus. Spleen on this side, liver on that side, heart is towards the right side. So that is a problem. Cilia are important for us. How do you identify cilia in histological picture? As I told you, I cannot zoom it too much, but they'll be appearing as a surface projection, like you can see here. Also, it is a schematic diagram. Thread-like processes. The point is, your eyes must be trained to identify cilia from keratin or from microvilli. How do you do that? Practicing more and more of MCQs. Now, this is cilia. What about this diagram here? As we move up, you will find it is written here as K. And what is K? The keratin. How do you identify keratin? First of all, you can see it is a stratified squamous epithelium, multilayered epithelium. Basal cells are columnar, middle cells are cuboidal, superficial cells are flat, squamous. I'll draw a schematic diagram also. But on the top of that, can you see this pinkish running layers? This is how the keratin will appear. Like on the skin, you have keratin, keeping the surface dry. You want to keep the surface dry. Keratinized, stratified, squamous epithelium. So in here, you can see basal cells are columnar, middle layer cells are cuboidal, and superficial cells are squamous. How do you know which cell is columnar, cuboidal, or squamous? By looking at the nucleus. Look at the shape of the nucleus. Let me draw it myself. As you will notice, if this is, say, the basement membrane, here we are showing the basement membrane. Looking at the cell, let us represent in red color, because cytoplasm will take eosin, pinkish color. The nucleus, if you focus, you will find oval basal nucleus. So when there is oval basal nucleus and more of cytoplasm above the nucleus, it is columnar cell. Though this one is columnar cell. How do you identify cuboidal? For cuboidal, you will find the shape of the cell is such, height is equal to breadth. In columnar, height is more than the breadth. In cuboidal, the height is equal to breadth, and there will be a central spherical nucleus. So central spherical nucleus, that will be a cuboidal cell. And how do you identify the squamous cell? For squamous cell, you will find it is a flat cell with the flat nucleus. So just by looking at the nucleus, if you find it is oval basal nucleus, columnar, if it is central spherical nucleus, cuboidal, and if it is flat cell with flat epithelium, squamous. And that is the arrangement you find here, stratified squamous epithelium. But the point here is, in such a diagram, your eyes must be trained to find whether it is keratinized or not. So it is keratinized because you can see keratin on these cells which are having the flat. Let me take the other color. The flat nucleus, you see, these are the flat nuclei, squamous cells. These are the columnar cells, basal, and these are the cuboidal cells in the middle. I hope I'm making my point clear. You'll be given diagrams and you have to identify which type of epithelium is that, which kind of surface projection is that. Now, as we move on, you see, what about this epithelium? This also comes in the exam. U here is representing the urothelium. It is representing urothelium. Now, what is urothelium? Tell me, what is urothelium? Let me just try to interact with the students as well. Just like Arjuna, focus on bird's eye. Yes, that is how I teach, and that is how you should study. Focus should be there. No, it is not pre-recorded. I am live in front of you. Urothelium, transitional. English please. इंग्लिश में बोलूं तो उसमें कुछ ऐसे भी लोग होंगे जो समझ नहीं पाएंगे. मैं मिक्स करके बोलता हूँ फिर अच्छा रहेगा. ट्रांजिशनल बिल्कुल आपने सही पहचाना है. आप सारे के सारे अच्छे खासे हार्ड वर्किंग लोग हैं और बहुत बढ़िया. साइटस इन्वर्सस आपने बताया, म्यूकोसिलियरी क्लियरेंस आपने बताया है. बहुत बढ़िया, बहुत बढ़िया. ठीक है, तो ट्रांजिशनल कैसे आपने पता करा ये ट्रांजिशनल है? देखिए, मैंने कहा कि एक तो आपकी आंखें ट्रेन होनी चाहिए. आपने इतने एमसीक्यू करे होने चाहिए कि देखते ही विद इन फ्यू सेकेंड्स यू शुड बी एबल टू आइडेंटिफाई. बट वन थिंग इज विच वी हैव जस्ट डिस्कस्ड, इट अपीयर्स स्ट्रेटिफाइड. You may confuse it with the stratified squamous epithelium. But it is not stratified squamous epithelium because the superficial cells towards the lumen, they are not flat cell with flat nucleus. Flat cell with flat nucleus. That is a feature of stratified squamous, not transitional epithelium. In transitional epithelium, the superficial cells are larger and globular and umbrella shape. U is also for umbrella shape. Now, when you say U is also for umbrella shape, can you see like during rain, बारिश जब होती है, किसी एक इंसान के पास छाता है, बड़ा है, तो 4-5 लोग उसके नीचे आ सकते हैं. एक आदमी के पास छाता, बड़ा छाता और 4-5 लोग उसके नीचे. क्या आप ये देख पा रहे हैं? यहाँ पर ये जो है एक सेल है, लार्ज ग्लोबुलर सेल, उसके नीचे 1, 2, 3, 4, 5 न्यूक्लियस, 5 सेल नीचे आ गए. मतलब जो ल्यूमेन की तरफ का सेल है वो बहुत बड़ा होता है कंपेयर टू द स्ट्रेटिफाइड स्क्वामस, जो बहुत ही छोटा और पतला सेल होता है. तो ये स्ट्रेटिफाइड स्क्वामस का अपीयरेंस है जो कि आप यहाँ पर भी देख पा रहे हैं, और ये यूरोथेलियम का अपीयरेंस है. ये सेल जो होता है जो ल्यूमेन की तरफ है, इसकी खासियत यह है कि स्ट्रेचेबल है. इसके पास रिजर्व सेल मेम्ब्रेन होती है, स्ट्रेचेबल है. यूरोथेलियम जैसे कि यूरेटर या यूरिनरी ब्लैडर. इफ यू टॉक अबाउट यूरेटर और यूरिनरी ब्लैडर, दे बेसिकली take care of the movement of urine and storage of urine. If urinary bladder is full of urine, the cell will stretch, and if urine is not available in the urinary bladder, there will be a flaccid bladder and the cell will relax. So stretchable epithelium, urothelium, and this is the appearance as you must train your eyes for. There is one more cell type and surface projection which is coming recently, and what they are asking is about this kind of appearance. Now, some of the students might get confused that this appears to be cilia, but it is not cilia. How do you identify cilia from the microvilli? This is microvilli. Microvilli are surface projections, and they are to increase the surface area of absorption. That could be in the intestine, small intestine. So small intestine will have this microvilli, and this is how it appears. How it appears? It is like thin pinkish line above the cells of the epithelium. So this is how the microvilli will appear. Now, why would you say this is microvilli? Why it is not cilia? Because cilia, first of all, they'll be taller, And second, cilia are thread-like. They are like this. Sometimes clumped, because you are preparing it in the slide. During preparation, the threads, they are clumped, one here, one here, one here, like, let me show you. In this diagram, we have seen the cilia. Cannot zoom too much, but you can notice that thread-like processes and clumping of those threads. This is cilia, this is keratin, and this is the urothelium, and that is microvilli. Now, where do you find microvilli? As I told you, could be the small intestine to increase the surface area of absorption. Where else? It can be in the proximal convoluted tubule of the kidney to increase absorption. PCT in the kidney. Where do you see urothelium? I have given you example, ureter and urinary bladder. And what about this stratified squamous epithelium? Stratified squamous epithelium comes a lot many times. If it is keratinized, you can say skin, and if it is non-keratinized, non-keratinized means it will be wet surface, then it is not dry. And one good example is deeper portion of oral cavity, esophagus and the vagina. So vagina has same epithelium as esophagus. What is the epithelium? Non-keratinized stratified squamous epithelium. This kind of epithelium is protecting us against abrasions. Abrasions. If it is skin, it must be keratinized. This keratin can be seen only on dry surfaces, not the deeper oral cavity or esophagus or vagina. These are the questions. I always teach in the format of questions. The type of questions you already got have a chance of getting repeated again. And where did you mention about the ciliated epithelium? First of all, can you see multiple level of nuclei? Appearing stratified but is not. It is pseudo-stratified. So this is how the pseudo-stratified cells will be, epithelium will be appearing. Pseudo-stratified ciliated columnar epithelium. One good example is respiratory tract. We talked about chronic sinusitis. That is where this kind of epithelium is there. So respiratory epithelium is pseudo-stratified, ciliated, columnar epithelium with goblet cell. Why do you need goblet cells? They'll secrete the mucus. In the mucus, the dust will come, bacteria will be trapped, and you can move it out, cough it out. So here we trained our cells into various type of epithelia and the sites where they can be found. Let me see if there are any queries in this relation. Yes, pseudo-stratified, mucus, yes, correct. Dr. Manpreet, skin, esophagus, yes, PCT, right. Rafiq, microvilli. So as I find, most of you are already prepared. You just need fine tuning, chiseling. And a teacher does nothing but just guide you into the right direction. That's my point. Sometimes we go off axis, means off track. Destination is there. We are working hard, but we don't know like where to move. So a teacher will just guide you, go in this direction. And the point is, each year there is a modification of the pattern of the exam. These kind of questions are very rarely asked now. Now what they ask is clinical questions. Carter syndrome. Asking you to identify epithelium is becoming rarity, and asking it in relation with the pathology. Histology goes into pathology or medicine or dermatology. So clinical based questions are more these days. We are here for 1.5 hours and 3 days. So we'll try to manage as many important topics which are possible. That's what we are doing. I am answering your questions which are in the chat, and let us continue. Now, as we are moving further, you will notice this is one topic which is very frequently appearing again. And what is that? Joints. Classification of joints can be seen here in this particular table. And they ask you the type of joints and their examples, various places. So let us do that. Arthrology. Now, as we talk about the classification of joints can be classified according to the freedom of mobility, restricted mobility or freely mobile joint. If we say restricted mobility, then you will notice fibrous joints and the cartilaginous joints, they have restricted mobility. But synovial joints are freely mobile joints. Before we start talking about freely mobile joints or synovial joint, let us focus upon the restricted mobility joint. The very first subtype of the joint is the fibrous joint. Two bones held together by some fibrous element, could be collagen fibers. Now, fibrous itself is three subtypes. What are the three subtypes? That is the suture, the gomphosis. Here is the gomphosis, and then you will find that there is one which is called as syndesmosis. Syndesmosis. Desmos means fibers. Let me zoom this a bit. You will notice that fibers are three types, and the very first is suture. Where do you find the sutures? Sutures are found in the skull. One bone, say parietal bone, meeting with other parietal bone in the midline. This is the suture. Two bones held together by some collagen fibers. One question came to you and it was asking about the shindialysis. Let me mention the term here, shindialysis. So what is shindialysis? Shindialysis is type of a suture which you find in the nasal septum at the roof of nasal cavity. You know, there's a vomer bone which is contributing to the nasal septum in the midline. And there is rostrum of sphenoid which is coming from above at the roof of nasal cavity. So sphenoid bone and the vomer bone, spheno-vomerine joint. Spheno-vomerine joint is a suture, and that suture specifically called as shindialysis, already one of the FMGE question. One is suture in fibrous variety. What is the other? Gomphosis, tooth and the socket joint. So tooth and socket joint, where the tooth is moving into the socket, which could be lower bone, the mandible, or upper bone, the maxilla, is a fibrous joint. They are immobile, they don't move at all. Now, what about the third variety under fibrous category? It is called syndesmosis. And as you talk about syndesmosis, this came as a question very recently to you. Middle radial ulnar joint. Middle radial ulnar joint. The radius bone connected with ulnar bone with some collagen fibers. Middle radial ulnar joint is which type of joint? And as we are mentioning, it is syndesmosis. Desmos is fiber, it's a fibrous joint. But it is slightly mobile, slightly mobile. Now, if you are talking about the radial ulnar joint, you'll find there is a superior radial ulnar, there is inferior radial ulnar, and they are synovial joint, freely mobile. They help us to rotate radius on ulna. What happens when you rotate the radius on ulna? You can do pronation and you can do supination. So which bone moves? It is radius, rotates to do pronation and supination, happening at which joint? Superior radial ulnar, inferior radial ulnar, but they are synovial joint. Which synovial joint they are? They are called as pivot synovial joint. So pivot synovial joint, but this discussion at the moment is not on the synovial joint. This is on fibrous joint. The middle radial ulnar joint is slightly mobile joint. It will be contributing to the supination pronation slightly. Chiefly, the movement happens at the freely mobile joint, which are synovial joint. So what we did here was talk about the classification of joint. How we are classifying the joints? On the freedom of mobility. And what are the categories? Fibrous, cartilaginous, synovial. Synovial are freely mobile, restricted mobility is fibrous and cartilaginous. Fibrous is three subtypes, the sutures, gomphosis and syndesmosis. Now, what about the cartilaginous? Two, primary and secondary. Primary is also called as synchondrosis and secondary is called as symphysis. Primary is immobile joint and secondary is slightly mobile joint. Let us zoom this area now. Here we are talking about the cartilaginous variety, primary, secondary, and as we say, this is primary. One example is in the growing children. Growing children will have growth plate like humerus bone, the shaft, and the head of the humerus. Between the two you have a growth plate in growing children. So when we are talking about this growth plate which is shown here, it is hyaline cartilage. Hyaline cartilage growth plate in growing children. Now this is the head of the humerus making the shoulder joint, and this is the shaft of the humerus here. Shaft is also called as diaphysis and one end of the bone is called as epiphysis. So question will come as epiphyseal-diaphyseal joint. Epiphyseal-diaphyseal joint where one bone is held with other bone with the help of a piece of hyaline cartilage, the growth plate. So epiphyseal-diaphyseal joint in the growing children is which type of joint? Your answer is primary cartilaginous. What is the other name of primary cartilaginous? Other name of primary cartilaginous is synchondrosis. Now, what do you mean by chondro? Chondro means cartilage. It is the cartilage joint. Synchondrosis is primary cartilaginous joint and it is immobile. What happens to this growth plate in the adults? It will change into bone and there will be a bony fusion. So, epiphyseal-diaphyseal joint, which is a synchondrosis, is seen only in the growing children. What about the adults? It will change into bony fusion, which is called as synostosis, bony fusion. So in the adults, it will change into synostosis. Does that mean we don't have synchondrosis in the adults? We don't have synchondrosis at this location in the adult because it changed into synostosis. But we can have synchondrosis in the adults at other places like xiphisternal joint. The xiphisternal joint is a synchondrosis. Ribs meeting their costal cartilage, costochondral joints. Rib with their costal cartilage, costochondral joint, they are synchondrosis. So we have synchondrosis in the adults also. But we do not have this synchondrosis in the adult because it is a kind of exception that it became synostosis. Now this is immobile. What about the secondary cartilaginous? If we talk about secondary cartilaginous, as is evident here, one example is pubis symphysis. This came to you at least 2 times, I believe, FMGE exam. So pubis symphysis where one hip bone is meeting with other hip bone in the midline, secondary cartilaginous joint or symphysis. For example, pubis symphysis, slightly mobile joint, slightly mobile. One other example of symphysis is midline intervertebral joint. What is the structure of symphysis? You will see that there is a bone meeting with other bone and they are already lined by some hyaline cartilage. So one vertebra lined by some hyaline cartilage here, the other vertebra also lined by some hyaline cartilage here, and sandwiching the two vertebra, there is another structure which is called as intervertebral disc, which is made up of fibrocartilage. So one vertebra is separated from other vertebra with the help of hyaline cartilage plus fibrocartilage. Intervertebral disc is fibrocartilage. It is like a shock absorber. Between two vertebrae you keep a shock absorber, that is intervertebral disc, and it is made up of fibrocartilage. Bone, hyaline plus fibrocartilage, midline intervertebral joint are also symphysis. They are slightly mobile. One example of this type is here. You can call it as the sacrum coccyx joint, sacrococcygeal joint. So sacrococcygeal joint is a symphysis, slightly mobile joint. Another question comes to you. Which type of collagen do you find in the bone? Like this vertebra, which type of collagen? If you are talking about the bone will have type 1 collagen. And the fibrocartilage like intervertebral disc. Intervertebral disc will also have more of type 1 collagen. So bone or fibrocartilage, they have type 1 collagen. What about the hyaline cartilage? Hyaline cartilage or the elastic cartilage, they have type 2 collagen. Type 2 collagen. Type 2 collagen in hyaline cartilage, type 1 collagen in fibrocartilage. What about the basement membrane? In the basement membrane of epithelium, type 4 collagen. Type 4 collagen, basement membrane. What about the healing tissue? Recently some injury was there and some healing tissue, granulation tissue. Recent healing granulation tissue, which collagen? Type 3 collagen. So type 1, 2, 3, 4 collagen. Type 1, bone and the hyaline cartilage. The bone and the fibrocartilage is type 1. What about type 2? It is the hyaline cartilage and the elastic cartilage. What about type 3? Type 3, you can see, is present in recent healing tissue, granulation tissue. Type 4, basement membrane, like that. Now, as we are proceeding through this discussion, I'm telling you, whatever we are discussing in this class, there is high probability that this kind of questions will be appearing in your recent coming exams. Yes, one student is asking, inferior tibiofibular. Inferior tibiofibular, which is near the ankle joint, will be syndesmosis. It is a fibrous joint. So two examples of fibrous joint. The two examples of fibrous joint are middle radial joint and inferior tibiofibular joint. It is also syndesmosis near the ankle joint. Syndesmosis. Now this was primary cartilaginous synchondrosis. This is secondary cartilaginous, the symphysis. What about the synovial joint? Because many questions come to you on the synovial joint. So this is one of the question which came in the synovial variety, which is freely mobile joint, synovial joint. What is this shown here? You find that there is the vertebra shown here and the ribs coming posteriorly. So ribs go posterior and articulate with the vertebra. Costovertebral joint. Now costovertebral joint is also at 2 points. One where the body of vertebra is articulating and the other where you have the transverse process of the vertebra articulating with the rib. So costo is the rib, costotransverse joint or costovertebral joint. Now may it be the costotransverse joint or costovertebral joint, both of them are plain synovial joint, freely mobile joint. Why do you need the freely mobile joint of the rib with the vertebra? Because ribs are mobile. We breathe. When we breathe, the ribs move. So mobility is provided by plain synovial joint. There are some other questions which will be asking you about the examples of synovial joint. Let us discuss some more examples under synovial joint. Like you will find there is this diagram here. They can ask you about malleus and incus joint. So if we are talking about the middle ear cavity, malleus and incus, middle ear cavity, malleus incus joint, saddle synovial joint. Now once you say it is saddle synovial joint, malleus incus, the ear ossicles, name some more saddle synovial joint. Two examples in the upper limb. Saddle synovial joint, two example in the upper limb are: number 1, sternoclavicle joint; number 2, first carpo-metacarpal joint. They are saddle. So sternoclavicular joint, the joint where we can do shoulder abduction. Though shoulder abduction is basically happening at shoulder joint, of course, but this joint helps us. Which joint? Sternoclavicular joint help us in shoulder abduction. Which type of joint is that? Freely mobile. Type is saddle. And what is this example here? First carpo-metacarpal joint between base of first metacarpal and trapezium bone. What is it doing? Thumb apposition. Counting the finger. Thumb apposition mostly happens at first carpo-metacarpal joint. Which type of joint is that? Saddle. Can you give one example of saddle in the lower limb? In the lower limb, example of saddle is, as we see, lateral longitudinal arch, the CC joint. CC joint in the lateral longitudinal arch. What is CC joint? Heel bone, calcaneum and cuboid. So calcaneo-cuboid joint. This calcaneo-cuboid joint, which is making the lateral longitudinal arch, is a saddle synovial joint. So we have learnt 4 examples under the category of saddle. Which 4 examples under saddle? Malleus incus and sternoclavicle and first carpometacarpal and lateral longitudinal arch in the foot, CC joint. Then they ask you ellipsoid synovial joint. What about the ellipsoid synovial joint? As we talk about ellipsoid synovial joint, you can take some example like 2 in the upper limb. Which 2 example in the upper limb? The wrist joint and the knuckle joint. So what is the other name of wrist joint? The other name of wrist joint is radiocarpal joint because it is a joint between radius bone and the carpal bones. Be careful, in the wrist joint, ulnar bone do not participate. That is why it is being called as radiocarpal joint. No ulnar participation at wrist joint. It is radiocarpal joint, no ulnar. Okay, so radiocarpal joint or wrist joint is which type? Ellipsoid synovial joint. And one other example in the upper limb, which is ellipsoid, knuckle joint, metacarpophalangeal joint. So metacarpophalangeal joint is also ellipsoid. Yes. One more example of ellipsoid. Skull vertebra joint, atlanto-occipital joint, atlas bone, C1 vertebra, occipital bone, the skull. So skull and vertebra, where you do this movement? Yes movement or nodding movement. Where is yes movement or nodding movement happening? Skull moving on vertebra, C1 vertebra, atlas vertebra, joint. Joint is atlanto-occipital joint, which is for yes movement and which is also called nodding movement. So nodding movement or yes movement, which type of joint is that? Ellipsoid. Now be careful because some of the books will tell that these are not ellipsoid. They will tell that these joints are condylar. Now if you say these are condylar, what does that mean? What should I answer if the question comes? Question could be radiocarpal joint, wrist joint, or metacarpophalangeal joint, or atlanto-occipital joint. Which type of joint is that? I mentioned ellipsoid, but some books telling condylar. What to do? First answer should always be ellipsoid. If not found in the option, then you can consider them as condylar also. But they are poor example of condylar. Now if these 3 are poor example of condylar, can you give some good example of condylar? If you look for the good example of condylar, then you can talk about temporomandibular joint or the knee joint, femorotibial joint. So good example of condylar are temporomandibular joint and the knee joint, which is also called as femur condyle, tibia condyle, femorocondyle, knee joint. But then be careful, despite the fact that temporomandibular joint and knee joint are condylar, some books will say they are modified hinge joint. Now if some books are calling them as modified hinge joint, what is the message here? Message is you keep practicing more and more of MCQs. See, we make mistakes and we have to minimize our mistakes. And how do we minimize our mistakes? By practicing more and more of MCQs. So what is the message here? Message here is temporomandibular joint, knee joint are definitely condylar, but you may find a question where condylar is not in the option. Then what is your second answer? Backup answer. You can also call them as modified hinge joint. But if modified hinge is in the option and condylar is also in the option, then obviously for temporomandibular joint, knee joint, the first answer should always be condylar. Similarly, if somebody asking wrist joint or knuckle joint or atlanto-occipital joint and you have both options, that is ellipsoid and condylar, which is the first answer? Preferably, ellipsoid is a better answer than condylar. Now you might think that what is the use of knowing all this information as a MBBS graduate? That is a good question. But you will realize it when you are actually an orthopedician. talking about kinematics, kinodynamics, then you will realize what is the importance of knowing the articular surface is elliptical or condylar, but not yet. At the moment you are just plain MBBS and you may not realize what is the importance, but questions are coming. So you must be ready for them. This is about the joints. We have discussed some of the synovial variety examples, and now we can move on to the next topic in our discussion, which is neuroanatomy. I will take some of the important questions related topics as I suggested. If you are asking about C1, C2 joint, which is atlantoaxial joint, that is a rotatory joint, pivot synovial joint, as the chat is asking. It is for no movement, no movement. C1, C2, atlas axis, atlantoaxial joint. It is for no movement. It is a rotatory joint, pivot synovial joint. And then mnemonic. See, mnemonic I usually don't give mnemonic. And why you don't give mnemonics? Mnemonics are just like making a lion as your pet. If you make the lion as your pet, you never know when the lion might go berserk and eat you only. Mnemonics are very dangerous actually. And if this lion is my pet, I should keep it with myself, not give it to you, because that pet is mine. Point is, if you wish to have mnemonic, you make your own mnemonics, then it is always better. If you want to pet a lion, you pet a lion yourself. If you kind of, you are taking my lion into your home, and it is very dangerous. At the right time, it will ditch you. In the exam hall, you remember the mnemonic, but you don't know what is the extension of mnemonic, because that mnemonic was mine, not yours. Most of the time, I won't use any mnemonics, and if I use mnemonics, I'll keep on stressing again, so that you remember it well. Mnemonics are very dangerous, It's better to remember the information itself. And then you will ask, sir, but how do I remember the information? By practicing more and more of MCQs. Mnemonics are very dangerous, take it from me. If you are really interested in making mnemonics, make your own mnemonics. That is my, this is my wisdom, and you will realize it only when you suffer the consequences, maybe. Anyways, PDF मिलेगा सर. अब जैसे कि ये मैं यहाँ पर वन नोट में बना रहा हूँ, वन नोट का PDF मैं बना दूंगा, मैं PrepLadder को लिंक भेज दूंगा, और वो जो लिंक है आप डाउनलोड कर लेना, PDF आपको मिलेगा, नो इशू, ठीक है. और एल्बो जॉइंट की अगर आप बात कर रहे हैं तो वो हिंज जॉइंट होता है, एल्बो हो या इंटरफिलेंजल जॉइंट हो. इंटरफिलेंजल जॉइंट हिंज होते हैं, हिंज जॉइंट, और एल्बो जॉइंट भी हिंज जॉइंट होता है, एंकल जॉइंट भी हिंज जॉइंट होता है. 3 एग्जांपल हिंज के, इंटरफिलेंजल जॉइंट, एल्बो जॉइंट एंड एंकल जॉइंट आर हिंज जॉइंट, whereas the knee joint and temporomandibular joint are modified hinge joint. Lot of information, actually too much of information, but you're talking about human body, and it is like that. Please annotate PDF fully. अब यार ये हर चीज़ 1 घंटा के समय दिया है, उसमें भी PDF को annotate करें, कैसे पढ़ाएं भी साथ में, it's difficult. I'll try. Radial ulnar joint has pivot, yes, superior inferior. Syndesmosis is middle radial ulnar joint. Sir, radial ulnar joint has pivot and syndesmosis, which is more. If a question comes, radial ulnar joint is, and they have not mentioned superior, inferior or middle, then you go for pivot synovial joint, because if they simply say radial ulnar joint, you have to take it as superior, inferior radial ulnar joint, which is actually pivot synovial joint, rotatory joint, radius rotates. But if I specify middle radial ulnar joint, then you say syndesmosis. So be careful about that. How many years previous year question to be solved? Last 5 years. No doubt about it. If you are comfortable with the 5 years, last 10 years. Don't go beyond 10. Don't go beyond 10. I have seen so many MCQs books talking about question which came 20 years back. Things have changed. Information has changed. Anatomy has not changed, but the knowledge of anatomy has changed. So don't go beyond 10 years. Keep restricted to last 5 years, maximum 10 years, that's all. And that will be too much for you to hold. Take care of those things. Or talocalcaneonavicular in the foot, medial longitudinal arch. If you say talocalcaneonavicular, it is medial longitudinal arch and it is ball and socket synovial joint, like shoulder joint, ball and socket, hip joint, ball and socket. Medial longitudinal arch in the foot, talus, calcaneum, navicular, ball and socket. Fourth example of ball and socket, incus and stapes in the middle ear cavity. Incus and stapes in the middle ear cavity is also ball and socket. So give, for example, of ball and socket. See, very simply, shoulder and hip joint are ball and socket. Incus stapes is ball and socket. Talus, calcaneum, navicular in the lower limb, foot, medial side, medial longitudinal arch is also ball and socket. That is what you asked. Okay. First year FMG student. First year FMG student depends like where are you studying, but the best thing will be, if possible, study more and more in the lab, like dissection hall, cadaver. Cadaver is the best teacher in the first year MBBS. Cadaver can teach you a lot more than what you can learn from the books. But the thing is, like there should be a good teacher in front of you, or you should be too much dedicated to follow books like Cunningham and all that. Saying is easy, I understand. Doing it is difficult, but cadaver is the best teacher in anatomy, I can say that. Now histology, of course, the slides. Neuroanatomy, of course, the sections. How many questions can you expect from the 5 years? 80%. 80%. 80% questions will come from the last 5 years, not the questions, topics. Questions may not repeat. Questions may not repeat exactly the same, but topics will be repeated. Say for example, if I'm talking about neural tube, development of nervous system, they'll keep asking, when is anterior neuropore closing? What if it is not closing? When is posterior neuropore closing? What if it is not closing? Open neural tube defect, the prophylaxis by folic acid. Repeated topics may not be questions. Last 5 year, 80% questions will come from the last 5 year topics. Take it from me. I have seen this system for at least 12 to 15 years. I have been teaching FMGE students. Okay, so let me just continue with the topics. And as I told you, neuroanatomy development, you have to understand that there is a process called as gastrulation, formation of 3 germ layers. So gastrulation is embryology, formation of 3 germ layer, which is first to form is endoderm, then is mesoderm, then is ectoderm. Endoderm, which is inside, mesoderm, which is in the middle, ectoderm, which is on the outside, in a sequence. First to form is endoderm, last to form is ectoderm. But then recently there is a new concept, 4 germ layers. Which is the 4th one? Neural crest cell. But where are these 4 germ layers coming from? They come from what is called as the epiblast cell. So there is a cell which is called as epiblast cell, and it is the epiblast cell which will be forming the 4 germ layers by the process of gastrulation. Epiblast will form the 4 germ layers by the process of gastrulation, and as I told you, the very first is the endoderm, and then is the mesoderm, then is the ectoderm, last is the neural crest cell. Now neural crest cells are migratory cells. Neural crest cells, they come from epiblast, they are migratory cells. They migrate. What will happen if there is abnormal migration, like a question which keep coming all the time? Abnormal migration of neural crest cell to the head neck region. DiGeorge syndrome. So DiGeorge syndrome is a problem of neural crest cell migration. What will be the problem? Problem is, in DiGeorge syndrome, we may not have a proper formation of the skull bones. specifically the facial skeleton, because facial skeleton is formed by neural crest cells. So these patients with DiGeorge syndrome may have small mandible. They will have pharyngeal arch defects. Like a question comes, in DiGeorge syndrome, because neural crest cells did not come in the pharynx, they did not stimulate the pharyngeal pouches, and pharyngeal pouches did not make what is called as thymus and parathyroid gland. So this is very frequent question. Question is on DiGeorge syndrome. What is the problem in DiGeorge syndrome? Problem is abnormal migration of neural crest cell. Why? What happened? Neural crest cell did not come here. There was some problem with the facial skeleton. There was problem with the pharyngeal arches. Like what problem? Neural crest cell is important to come to pharyngeal arches and stimulate the endoderm to give pharyngeal pouch derivative. So pharyngeal pouch 3 and also 4 will be affected. If you have to choose, 3 is first answer. Pharyngeal pouch 3 is compromised and 4 is also compromised. Now if pharyngeal pouch 3 is compromised in DiGeorge syndrome, what does it give? It gives thymus and inferior parathyroid. You can remember a mnemonic like your mnemonic. I told you I very rarely give mnemonic, but if I give, I'll make sure you remember it well. So what is my mnemonic? PP3 tip. Now what is this PP3 tip? Pharyngeal pouch 3, PP3, pharyngeal pouch 3. It gives T, the thymus, and IP, inferior parathyroid. In DiGeorge syndrome, the tip will be missing, means thymus will be missing and inferior parathyroid will be missing, and that could be a problem, because there can be cell mediated immunity down because thymus is down, hypoplasia of thymus, and inferior parathyroid is missing. That means there can be problem of hypocalcemia. We'll discuss this again. At this moment, what I wanted you to understand is neural crest cells are important at various places. One is to form the peripheral nervous system also. Now, if neural crest cells are important to form peripheral nervous system also, what do you include there? Ganglia. So ganglia are mostly from neural crest cells. Ganglia means peripheral nervous system and they are from neural crest cell. For example, Hirschsprung disease in the large intestine. Large intestine, Hirschsprung disease, neural crest cells are migratory. They did not go to the colon. No ganglia. There will be a ganglionic colon. So that aganglionic colon is Hirschsprung disease. It is congenital because since birth. So congenital aganglionic, and because it is aganglionic, it cannot evacuate the fecal matter. Movement is not there, ganglia is not there, movement is not there. It becomes large colon, mega colon. So the full name is congenital aganglionic megacolon. Congenital since birth, aganglionic no ganglia, mega colon loaded with fecal matter, unable to defecate. The baby is unable to defecate. So congenital aganglionic megacolon is Hirschsprung disease. Problem of again neural crest cell migration. They have to go to various places and form ganglia. If they don't form ganglia, aganglionic problem of motility and Hirschsprung disease. So if the neural crest cell is forming PNS, who is forming the CNS? What is CNS? Central nervous system. Central nervous system means, what do you include there? Brain and the spinal cord. So brain and the spinal cord is central nervous system. Who is forming the CNS? The CNS is basically coming from what you can call as the neural plate ectoderm. Ectoderm will be further dividing into surface ectoderm and neural plate ectoderm. So ectoderm further divides into neural plate ectoderm and surface ectoderm. Surface ectoderm will form skin epithelium and neural plate ectoderm will form central nervous system. That is what we are going to discuss now in this diagram. So as we are talking about this in this diagram, we are looking at the dorsum of the baby. a developing baby dorsum. What will be it covered by? Skin. And where the skin epithelium is from? Surface ectoderm. If you remove the skin, what do you find? Vertebra. You'll find vertebra. What is vertebra developing from? Mesoderm. Mesoderm. If you open the vertebra, what will be inside? The spinal cord. Where is spinal cord coming from? Neural plate ectoderm. So skin from surface ectoderm and spinal cord from neural plate ectoderm. These two type of ectoderm which we are talking about is looking on the dorsum of the baby, on the exterior. Exterior most is ectoderm. So one thing is looking from the dorsal view, and other thing is you are going to take a section like this. You are going to take a section also, and the diagrams are here. Now let us zoom these diagrams. As you will notice, first there will be a neural plate, then it becomes a neural groove, and then it becomes a neural tube. So neural plate, and as we can see, here is neural groove in a sequence, and this neural groove is going to fuse with, they also ask where it fuses, where the fusion begins, cervical region. Cervical region the fusion will begin, and it will convert itself into what is called as neural tube. So this neural tube, what you are looking at is like this in a simplistic term. First it was a plate, it became a groove, and it became a tube. And it is the neural tube which came from neural plate. Neural plate forms what is called as neural tube, and it is open right now. You can see it will have one neuropore here, another neuropore here, called as anterior and posterior neuropore. But be careful about these terms. It could be the cephalic or rostral is the other name. You can call it as cephalic or rostral or anterior. And what is posterior called? It is called as the caudal. It is the caudal. Now they'll ask you, when is anterior neuropore closing and what is formed? Anterior neuropore will close at day number 25, and it will form the brain. And when is the posterior neuropore closing? Posterior neuropore closes after 3 days. That is day number 28, and it will form the spinal cord. So brain and spinal cord, that is central nervous system. Where is central nervous system coming from? Neural plate ectoderm. So neural plate ectoderm will form the central nervous system by forming the neural tube. And neural tube is open in the beginning. It must close. Anterior neuropore will close day number 25 to form the brain. Posterior neuropore will close day number 28 to form the spinal cord. What if they don't close? Like there can be folic acid deficiency. Folic acid deficiency leads to open neural tube defect like anencephaly, and it is the open brain and small brain, anencephaly. I'll show you a diagram. And what about the non-closure of posterior neuropore? If it is non-closure of posterior neuropore, that could be resulting in rachis. Rachis. These are questions which come to you. But let us go back into the description, and you will notice now here, in the beginning, what we have is, say here, you can see, this is the ectoderm. And this ectoderm is divided into two parts. One which is to the periphery, surface ectoderm, and one which is in the center. It is, say, let us take this color, the neural plate ectoderm. So in the center there is a neural plate, and that neural plate becomes a neural fold, and that neural fold becomes a neural tube, which is forming here, but it has already formed here. And it is the neural tube which we have shown in the full. This is a transverse section, this is full scape, and this is the one which forms the brain and spinal cord. Now at the periphery of neural tube, or at the junction of the surface ectoderm and neuroectoderm, you will find what is called as the neural crest cells. These are the neural crest cells. So neural crest cells are at the junction of surface ectoderm and neural plate ectoderm, and this is the neural crest cell which will contribute to peripheral nervous system, the ganglia. The neural tube will form CNS, neural crest cell will form the PNS, and if they are properly not migrating, like we said, they are not reaching the colon, then there can be problems like Hirschsprung disease. Neural crest cells have a lot of derivatives. One of that is they are contributing to peripheral nervous system. Now here we were talking about the neural tube. Say let us denote the neural tube here on the dorsum of the baby, and somehow what happened, there was a deficiency of folic acid, anterior neuropore did not close. Small brain, degenerated brain, open brain, anencephaly. And if it is a problem with the posterior neuropore, rachis. Actually, examiner is giving you photographs and asking you to look at the photograph and identify the problem. Let us look at that photograph as well. You see these kind of photographs. So what is the problem here with the first baby? Problem with the first baby is small degenerated brain, as you can see, small degenerated brain, and it is open outside. Skull cap is missing. Skull cap is missing, small degenerated brain. Why it happened? Anencephaly. And anencephaly is due to non-closure of the anterior neuropore, which should have happened at day number 25. What about the other case here? Here you see that there is a defect in the lumbosacral region. There is open skin, open vertebra, open spinal cord, rachis. This is what you call as rachis. Now if you say this is the rachis, why it happened? It is due to non-closure of the posterior or caudal neuropore, which should have closed by day number 28. Spinal cord is open and CSF is leaking out. Even the vertebra did not close it properly. Spina bifida. There will be a spina bifida. And skin is also open. So rachis is open neural tube defect in the posterior portion, and anencephaly is open neural tube defect, which is in the anterior or cranial or rostral portion. You can prevent them by giving prophylactically folic acid, which is in the dose of 400 microgram per day. Now this is the usual dose, 400 microgram per day. But a lady came to you and she's telling, I already had a baby with neural tube defect. Means obstetric history of giving birth to a baby with open neural tube defect. Now what will you do in such a case? In such a case, you have to increase the dose, and it can be even 1000 microgram or 5000 microgram. That means 5 milligram per day. You can increase the dose of folic acid to this level if you are having a obstetric history of giving birth to a similar kind of baby earlier. The lady will definitely tell you that. If anything of that sort happened, then you have to increase the dose of folic acid. It is a prophylaxis of preventing the open neural tube defect. So these are all MCQs which come to you, and our teaching is specifically based upon that. Now one question came to you. It was asking about the Broca's area getting connected with the Wernicke's area. Now what is this Broca's area and what is this Wernicke's area? They are basically connected by something what is called as arcuate fascicle. First of all, you are looking at the cerebrum. And second thing, you are looking it from the left side. Why left side only? Because if you talk about this Broca's area and Wernicke's area, they are language areas. And language areas are 95% of population more developed on the left side. So does that mean you don't have Broca's and Wernicke's on the right side? You may be having, but they're not developed as much as they are on the left side. So left hemisphere is dominant hemisphere, and most of the individual population, the Broca's and Wernicke's will be highly developed on the left side. Now, What is the purpose of having these areas? What is their numbers also? This is called broadband numbers. Sometimes they may ask you about broadman number. So what is the broadman number for the Wernicke's area? It is area number 22. And where is it located? It is in the temporal gyrus, a gyrus which is deep to the ear. Deep to ear, temporal gyrus. But on temporal gyrus also where exactly? Superior temporal gyrus. But on superior temporal gyrus also where exactly? Anterior or posterior? It is posterior. So posterior part of superior temporal gyrus is area number 22, which is Wernicke's area. What about the Broca's area? Broca's area is on the front, on the frontal lobe. But on the frontal lobe also where? On the inferior frontal gyrus. So Broca's area, inferior frontal gyrus, and the Wernicke's area, superior temporal gyrus, but more posterior, not anterior, it is more posterior. Area number 22, if you multiply by 2, 22 into 2, it becomes 44, and that is the Broca's area. Broca's area is 44 and 45, double the number of Wernicke's. 22 into 2 is equal to 44. 44, 45 is Broca's area. How do they get connected? By some axons, arc-shaped bundle of axon. Arc-shaped bundle is fascicle, arcuate fascicle. Arcuate fasciculus is connecting area number 22 to 44. But what is this all about? See, I am talking to you. I am writing something here. This is all language. You understand language, the spoken or written. How? How do you understand language? Wernicke's area help you in understanding the language, written or spoken. So Wernicke's area is for understanding or comprehension of language. And what is Broca's area for? Broca's area is planning the movement of speech muscles. Whichever muscles we use, lip, tongue, palate, pharynx, larynx, all these muscles, they move. The planning of their movement is done by the Broca's area. Broca's is motor speech area for planning the movement of the speech muscles. It doesn't move the muscle. It will just plan the movement of muscles. And this is Wernicke's sensory speech area. Now, if Wernicke's sensory speech area, what will happen if I have a lesion here? There is some artery, middle cerebral artery. Middle cerebral artery, there is a block. If middle cerebral artery, there is a block, there is ischemia in the Wernicke's area. What will be the problem? Problem will be Wernicke's sensory speech aphasia. And how do you know that it is Wernicke's sensory speech aphasia? Because these people, they don't understand the language. And not only that they don't understand language, maybe written or spoken, they continuously keep speaking. And their speech is non-stop and nonsense. They speak non-stop nonsense. Now, understood that they are speaking nonsense because they don't understand what they are speaking about, but why they are speaking it non-stop? Problem is that they have loss of insight. And what is loss of insight? Means they don't know that something is wrong with themselves. So loss of insight. They don't know something is wrong with themselves. They think that something is wrong with you people around them. So they just want to express themselves, and that is why. In OPD, you'll find there is one person who is sitting there and speaking continuously and non-stop and nonsense. You'll immediately identify this patient must be having Wernicke's sensory aphasia. He doesn't know that there is something wrong with him, and he doesn't know what he's speaking about. He doesn't know what you are speaking about because there is a problem with understanding, comprehension. On the other hand, you see in the OPD, there is a patient sitting on one side, doesn't speak at all, has a tendency to speak. Now, it is Broca's motor aphasia. Broca's motor aphasia. How do you identify these people? You identify them because they have hesitancy to speak. But why he is hesitant to speak? First of all, he knows that something is wrong with him. insight is there. So obviously he will not try to make other people uncomfortable. Second thing is that he has motor aphasia, means he cannot plan the movement of speech muscles. Lip is going somewhere, tongue is going somewhere, palate is going somewhere, movements are not articulated, articulation problem. So he knows that whatever he's speaking is not articulated properly. So rather speak less. They are having hesitancy to speak. They keep quiet most of the time. Now what will happen if I have a lesion in the arcuate fascicle? Then there is what is called as conduction aphasia. And what is conduction aphasia? In conduction aphasia, you will find the comprehension is intact, no problem in understanding. The speech is fluent, no problem in speaking fluently, but problem is that they have poor naming capability. They forget the names of the individuals. And they have poor repetition of language, poor naming, poor repetition of language. That is a feature of the arcuate fascicle lesion or conduction aphasia. Information from here to here was not conducted properly, conduction aphasia. So that is more of a medicine question. But my point is, in anatomy, this is called as association fibers. Association fibers. Fibers can be association, they can be commissure, they can be projection. This is association fibers, and association fibers connect one part of brain with the other part of brain without crossing the midline. It is on the left, it will stay on the left. So association fibers are axons which do not cross the midline. And what if the axons cross the midline? They are commissural fiber, like corpus callosum. Corpus callosum connects right brain with left brain crossing the midline. It is commissural fiber. What about internal capsule? Projection fiber, projection from upper brain center to lower brain center and vice versa. So internal capsule is projection fiber going up and down, higher center, lower center, projection fiber, internal capsule. If it is corpus callosum, commissural fiber. If it is arcuate fascicle, then it is association fibers. So this is one of the topic we wanted to take care of, because these are some of the latest questions which are coming. One latest question which has come was giving you simply a radiograph, which could be a CT scan, MRI, and asking you various parts of the brain. So let us label them and help you identify them if it comes in the exam. Okay, let me just go through the chat as well. And as I understand, most of you answer quite perfectly. That means you already are prepared quite well, and just need a little bit of push maybe, and you will definitely clear off your FMGE hurdle, FMGE screening exam. But maybe that should not be your target. Your target should be clear the hurdle of FMGE screening exam and then prepare for your PG entrance as well. You are in a momentum. Let the momentum go little bit further, and I don't see any problem at all in the answers which you are giving. Perfect. Right. Now, okay, you already have identified pons. Very good. Fantastic. So that is how it should be actually. You should be confident also and should be fast. You know what is this all about? Speed with accuracy. You have to be fast, but you have to be accurate also. And how do you do that? Practice more and more of MCQs. That's what you do. So, as you are looking at the side view, it is a sagittal section. Now again, you see sagittal section means you take anterior to posterior section, remove one half of the brain, look at the other half of the brain. Say for example, if you're looking from this side, you might have removed left half of the brain. So anterior posterior sagittal section, remove the left half of the brain, look at the right half of the brain from medial view. This is a anterior to posterior sagittal section. The clinical relevance of what we started our class with. Okay, so if this is the sagittal section, what are the various parts of the brain here? You have to start, let us say, with the largest part of the brain, cerebrum, and this is going to be the cerebrum. Now, if this is the cerebrum you are looking at, if it is towards the frontal lobe, and if it is towards the posterior, occipital bone, occipital lobe. This is occipital lobe, this is frontal lobe, okay. Now, that is cerebrum. How do you connect right cerebrum with the left cerebrum? There are some commissural fiber, corpus callosum, but in a sagittal section, that corpus callosum is appearing C shape. You will find this is the corpus callosum. This is the corpus callosum, which is nothing but the collection of axons and connecting right frontal lobe with the left frontal lobe with corpus callosum, and connecting one occipital lobe with the other occipital lobe with the help of corpus callosum. Right and left cerebral hemispheres are connected by corpus callosum. Then you will find this is the cerebrum, telencephalon, telencephalon. Then comes the diencephalon, thalamus, hypothalamus, diencephalon. Where is diencephalon? And let me zoom, if it is possible, little bit more. Diencephalon, you will find the telencephalon is holding diencephalon like this. So deep here will be the diencephalon. As we are mentioning, diencephalon means thalamus and hypothalamus. So where it is? You will find this region here is the diencephalon, and up is thalamus, below is hypothalamus. Now, if up is thalamus, below is hypothalamus, what is this? This is called as hypothalamic sulcus. Hypothalamic sulcus. Okay, this is diencephalon. What is below that? The brainstem, having three parts. So, what are the three parts of the brainstem? As you will see, the three parts of the brainstem, there will be a midbrain and the pons and the medulla oblongata. So, what are the three parts of brainstem? Midbrain, pons, where you have this arrow mark, and medulla oblongata. How do you know it is midbrain? Because it is below diencephalon. But still, how do you know it is midbrain? Let me erase it once, and then you will be able to identify something called as superior colliculus, inferior colliculus on the posterior side of midbrain, tectum, and this is going to be the tegmentum. If it is on the front, tegmentum of the midbrain. If it is on the posterior, tectum of midbrain. Rounded elevations, superior colliculus, inferior colliculus. Let me rub it again. See, the point is, if you are unable to identify it in the exam, then what is the purpose of teaching? So, I'll rub it and I'll show you again. You should be able to identify. Can you see some rounded elevations? Those rounded elevations are superior colliculus, inferior colliculus, tectum, posterior part of midbrain, and this is the tegmentum here. Okay, then what is this? This is, of course, the pons. Now, if you say this is the pons, what is behind the pons? Is the cerebellum. This is the cerebellum. And what is sandwiched between the pons and cerebellum? Pons anterior at the floor, cerebellum posterior as the roof. So, cerebellum posterior as the roof and pons anterior as the floor is sandwiching the fourth ventricle filled with CSF. This is the fourth ventricle which is filled with CSF, posteriorly cerebellum, anteriorly pons. Pontocerebellum, metencephalon, metaencephalon, pontocerebellum. Now, if that is pons, where is medulla oblongata? Medulla oblongata, let me change the color. This is the medulla oblongata, the one which passes through what you call as the foramen magnum. So, what passes through foramen magnum? What passes through foramen magnum in the occipital bone is medulla oblongata, part of the brainstem, and continue downward as Continue downward as say, let us choose some color, white color. This is the spinal cord. That is the spinal cord. So this is spinal cord, and that is the medulla oblongata. So remember, what passes through foramen magnum is medulla oblongata, not the spinal cord. Spinal cord is continuation of medulla oblongata, and it is in the vertebral canal, not in the foramen magnum. So these are various parts of the brain which the examiner might be interested. Can you tell me one thing here? What is this? Write in the chat, because it already came as a question. Tell me. I'll zoom it a little bit so that you become comfortable. Tell me. I'll rub it also. I'll rub it so that you are able to identify it properly. Tell me, what is this? Also tell me, what is this? What is this? Pituitary gland, fantastic. Not pineal, pituitary. And what is that bone? Where it is sitting? Body of sphenoid. What is that called? What is it? Sella turcica. Fantastic, fantastic. Sella turcica. So maybe that is a simple question. But the problem is, when it comes to you like this, you may not be able to identify until you keep practicing. Fantastic. So this bone is body of sphenoid at the floor of middle cranial fossa, and it is to keep pituitary gland. And pituitary gland also, pituitary gland, let me zoom this a little bit, will have a posterior part, and that posterior part is called as the neurohypophysis, is a downward extension of hypothalamus. Hypothalamus will give a downward extension which is called as posterior pituitary neurohypophysis. Hypothalamus, it's a part of diencephalon. What? The pituitary. Posterior pituitary. So posterior pituitary is an extension of diencephalon. Hypothalamus, downward extension, and it is neurohypophysis. Where is the anterior pituitary coming from? Anterior pituitary, which you can show here, is basically coming from, you will see here, let me zoom out, from the roof of oral cavity. It comes from the roof of oral cavity. And your question was Rathke's pouch. Rathke's pouch. So what is Rathke's pouch? First of all, Rathke's pouch is surface ectoderm at the roof of oral cavity. Rathke's pouch developed from surface ectoderm at the roof of oral cavity, and that Rathke's pouch surface ectoderm give you anterior pituitary, which is also called adenohypophysis. So adenohypophysis or anterior pituitary. Where is posterior pituitary coming from? I told you ectoderm will divide into two parts: surface ectoderm and neural plate ectoderm. Neural plate ectoderm will form nervous system. So that is nervous system. Posterior pituitary is from neural plate ectoderm. There are two types of ectoderm: surface ectoderm and neural plate ectoderm. The neural plate ectoderm form the brain, form the neurohypophysis. So neurohypophysis is from neural plate ectoderm, whereas adenohypophysis or anterior pituitary is from surface ectoderm at the roof of oral cavity, coming from Rathke's pouch. What will happen if there is a problem here? There is a tumor which is called as, the Rathke's tumor, or it is basically pituitary tumors, craniopharyngioma. So craniopharyngioma is a pituitary tumor due to abnormal formation of Rathke's pouch derivatives. So this is all I wanted to finish off in today's class, and I'm very hopeful, like whichever topics we are talking about, discussing in these sessions. There are 3 sessions. Today it was 1.5 hours. Then next 2 days, total 4.5 hours to 5 hours maybe. And we'll take care of some of the topics which are continuously, repeatedly asked in your FMG exam. So that is the last point which I wanted to put here. Let me just go through the chat. If you have any queries here, already you are answering. Craniopharyngium, fantastic. Rat case pouch, yes. Fantastic. Celatosica, yes. Sphenoid bone, yes. So, very good. Fourth ventricle, yes. Corpora quadriga minor, yes. These two superior colliculi, two inferior colliculi, together they are called as corpora quadriga minor. Corpora means bodies, quadri means four, four bodies, because two superior, two inferior colliculi. Tectum, corpora quadriga minor, perfect. And right, corpus callosum. PDF is pending yesterday's session. I'll inform PrepLadder team to send you the PDF. Pons, projection fiber, nonsense speech, yes. Like, if somebody who is not in medical and watch me speaking like that, some student already mentioned robotic kind of teaching, he will consider that I'm suffering from Wernicke's aphasia, nonsense, non-stop speech, because if he is non-medico, then he will understand nothing. Why he is continuously speaking something which I cannot understand, suffering from? For a non-medico, it is appearing like a Wernicke's aphasia. And loss of insight also. I don't know, like something wrong with me. Anyway, a little bit of humor will not hurt us. Okay, right. Thank you. Thank you. Today the session stops here, and tomorrow evening I'll see you again at 6 p.m. Take care.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe